So the ACE-001 study for myelofibrosis is really looking at, can luspatercept improve anemia in patients with myelofibrosis? This is a really big problem. Roughly 40% of patients will be anemic at the time of their diagnosis. In fact, it's one of the diagnostic criteria as determined by the WHO. And additionally, more patients over the first year or two of their disease course will develop anemia, particularly transfusion-dependent anemia. If you think about it, that's a huge burden on a patient. Not only do they feel terrible because they're anemic, but in order to get a transfusion, you have to come into the clinic, you get your type and cross, you have to wait for the results to come back, and then they get you your blood, and it's a whole day ordeal. And for some patients that are getting transfusions once or even twice a week, that's a big impact on their quality of life. Not to mention that anemia is associated with inferior survival in patients with myelofibrosis. So we need more and better agents, if you will, that can treat anemia in these folks, particularly those folks who are on a JAK inhibitor, like Ruxolitinib. And so that's what this study really set out to do. So Luspatercept is already FDA approved and EMA approved for the treatment of anemia and thalassemia, as well as anemia due to myelodysplastic syndromes. And in this particular study, we looked at 4 different groups of patients. Patients who were on Ruxolitinib, but not transfusion dependent. Patients who are on Ruxolitinib and transfusion dependent, and then the other half of the 2x2 table. So patients who are not on Ruxolitinib and not transfusion dependent, and those who were not on Ruxolitinib and transfusion dependent. So there were 4 different groups there. And really what we saw was in every group responses, people's either anemia improving or their transfusion burden decreasing. The tricky part is anemia and transfusion burden is really tough to measure, to be honest. There's no kind of widely accepted criteria for transfusion dependence to begin with. And lots of different things can affect red cell levels in patients. So I give one example. A patient could be on Luspatercept, let's say, and have a nice improvement in their hemoglobin, and then all of a sudden they get appendicitis and have to get an emergent appendectomy. And their hemoglobin then dips during that surgery because the surgeons put a big hole in the patient, and they may no longer be qualified as a responder, even though really it was an iatrogenic reason for their dip in their hemoglobin. So we saw a couple of those instances throughout the study where a patient would have a viral infection that would alter their hemoglobin or other things that are unrelated. So it's really, really tricky. Nonetheless, we saw a significant number of improvements in every category. The highest amount of improvement, if you will, seemed to be in patients who are on Ruxolitinib and transfusion dependent. That was the largest group of responders, whether we were looking at stringent hemoglobin levels, transfusion dependent levels, or more lax type of endpoints. That was the group that really seemed to benefit in the largest proportion. So this was an update of last year's abstract that we presented, and really showing that the duration of responses continued throughout the year, and really kind of made that case again to move forward in a phase 3 setting with Luspatercept in patients who are on Ruxolitinib and transfusion dependent. And thus the phase 3 study is launched and up and running.